year and joined the Hard Guys this year. Very happy and thank you. So we're going to talk about venous disease, but more just overview, lower extremity edema evaluation in general instead of just venous disease by itself. Is it the 2 years down? No, it's down there. There we go. So doc, all swelling, heart failure, not necessarily. So there's a lot of different reasons for swelling the leg, and you guys probably know a lot of this. I skipped a lot of the pathophysiology stuff because that's super boring. DVT, worsening heart failure, injury of the leg, less common compartment syndrome, pelvic tumor, May Thurner's for acute style lower extremity edema, and then more commonly we're seeing mostly chronic edema, especially in our office. I'm sure you guys are seeing it all the time as well. Venous insufficiency actually accounts for almost 30% of the lower extremity edema that we see in the office. Chronic heart failure, a decent amount of the other. Pulmonary hypertension, extremely common as well. Lymphedema, which we get consults for edema that end up being lymphedema all the time, and then treatment for that's obviously really tough, and I'm sure you guys see that all the time. And I'm glad I'm going first because some of my pictures are a little less friendly with our meals, and I'll get through that quickly. Medication, very common. Calcium channel blockers, gabapentin is a huge one too. You see it all the time in all of our patients, diabetics, hypertensive, they're all on gabapentin. And that can also cause a lot of lower extremity edema, a lot of cancer treatments, lower extremity edema as well. Less common, significant renal failure will be severe edema as well. And then in rare cases of patients that have had either gastric sleeve, more commonly the Roux-en-Y or a traditional gastric bypass will have protein malnutrition. And low protein stores can lead to lower extremity edema as well. The treatment is replete protein. I've had a number of cases like that. Older ladies, tea and toast, not enough protein, and lower extremity edema, just protein shakes and they do well. So doing a comprehensive history on patients. I diagnosed myself on the internet, and I'm only here for your opinion after that. Second opinion, maybe third. But short of breath, going to be more probably heart disease or pulmonary hypertension or something along those lines, maybe less likely venous insufficiency. Although a lot of things can overlap. Coronary disease, again, in their history, probably going to be more cardiac disease if they already have COPD or sleep apnea or something along those lines, then maybe a little less likely on the venous insufficiency pathway. Significant cancer, they're going to have lower extremity edema, maybe clotting disorder from that. Severe advanced kidney disease, end-stage renal. And then family history of any of the above. I mean, there's very common genetic inheritance for lymphedema, venous disease, so a lot of times the family history can be really helpful in which is going to be our diagnosis for edema. All right, here come the bad pictures. First one's not that bad. So stage 2 lymphedema, right? You got pretty classic Stemmer sign type stuff, but roll at the ankle, you got some skin toughening, maybe they've had surgery in the past, knee replacement I'm seeing a lot of lymphedema with, they've had pelvic surgery, pelvic radiation, something like that. More lymphedema now, the really gross one. So that's going to be stage 4 lymphedema. I can't help that person, right? That's going to be wraps and pumps and weight loss and venous ablation. Definitely. I don't even know if I get the needle through that thing. So that's going to be pretty tough. Pretty standard pitting edema. That's the toughest one, right? That's the heart failure, maybe venous insufficiency, maybe this, maybe that, maybe pulmonary hypertension. So that's going to be the more, what are we going to use for diagnostics for that patient to figure out what they actually have. And then lipedema, so just severe obesity, again, weight loss, diet, exercise programs, maybe wraps if they have cellulitis, but not much we can really be able to help with those patients either. And then, my video didn't play. So this is a severe tricuspid regurgitation and dilated right ventricle and severe pulmonary hypertension. So echoes in our office, that's a pretty common staple test that we do. For diagnosis of all heart disease, so we see that pretty readily on the echo, and then kind of guide our therapy. Okay, your edema is clearly not venous, you're going to be more in the cardiac realm, and then what are we going to do for those patients? So it's helpful in our office because we have all the testing right there that we can figure out exactly what's going on. Over here, we also do all the venous studies right in our office, venous insufficiency studies, significant reflux greater than half a second. This one's more like 3 seconds. Venous valve failure, and we're going to get into that in a few minutes, but all the classic testing for our office. So moving forward to more of our venous clinic, stationed in Marlton, expanding into Washington Township. And varicose veins, extremely common, edema of the legs again, and then the skin changes, more of that kind of flaky, discolored, brawny, pretty classic for venous insufficiency. And last stage being open wound, typically medial ankle, but can be lateral ankle too. Large, moist, irregular edges, unlike the arterial stuff that you'll hear from Dr. Raffet a little bit, or punched out white and circumferential. So on my only pathophysiology slide, is venous valve failure. So over time, genetics, pregnancies, obesity, injury, all the above, dilated veins, increased venous pressure, and leading to just frank venous valve failure and capillary leak. That's really what we're looking at for that, and painful varicose veins too, and sometimes bleeding episodes. So classification for venous disease is the SEEP classification. Most of us stop at the C. But you can do all of the above. So really the C classes are going to be just standard telangiectasias, varicose veins, edema, pigmentation, healed ulcer, and venous ulcer. And there is a 4A and a 4B also for real specific. But, most of us it's 4, 5, and 6. And open ulcer and healed ulcer really lead to a lot of morbidity and direct therapy. So we're doing most of these treatments in our office, which is great. We don't need a hospital stay. Most of these patients are in and out of the office for evaluation and treatment pretty quickly. Compression socks and elevation for basic standard treatment for patients that are SEEP 1 to 4, and kind of define that later again. It's going to be trial compression socks and see where we go. Salt restriction, water restriction, that type of stuff as well. And then permanent, old school surgical stripping. Thankfully, that's gone by the wayside. We're doing phlebectomy in our office, sclerotherapy, and endovenous ablation is really one of the first lines of it. This is endovenous ablation. This is radio frequency, which most of us are using. There's also laser. Pretty equivalent, a little less pain with the radio frequency. So it's ultrasound guided access. Under ultrasound, we bring the catheter up before the saphenofemoral junction. Heat is delivered after amount of anesthetic to the entire length of the saphenous vein. And then that causes sclerosis of the vein. So it's heat-derived sclerosis. And then everything comes out. Patients are wrapped and sent home. So it takes about 30 minutes in and out of the office in about an hour. No general anesthesia needed, and patients walk out the door. So it's,
they can drive themselves.
They can drive themselves if they want, because we're not doing anesthesia. So the ride's not an issue. They don't need an Uber, and they don't need all that other stuff. So it's pretty straightforward. Very low side effect. All done under ultrasound, sterile procedure in our office with a procedure room. So extremely effective and pretty safe and easy to do right in the office. Much different than traditional surgical stripping from 20 years ago, right? So general anesthesia, hospital operating room, significant pain, lots of scarring, recovery's long, and extremely high failure rates. I've seen so many patients stripping, they just took a small piece out and that was it, and the rest of the vein was left behind and still had significant reflux. Whereas ablation, it's local anesthetic, office-based, there's almost no pain other than just the local anesthetic. There's no scar, it's a pinhole. Extremely low side effect profile. Recovery is the same day. It's literally walking out of the office in an hour. And 97% effectiveness at 5 years. So it's pretty significant. It's the only one trial that's ever been done for endovenous ablation. It's called the ASHAR trial. And these are the main highlights, is that the real benefit is for reduction in recurrent wounds, whereas actual wound healing wasn't affected as much. So we still do a lot of active wound patients to do ablation on, just from a perspective, I've seen it a lot anecdotally. Where if wound patients that haven't been healing, we do ablation, they end up healing after a month or two. But from this particular trial, not a huge trial, compression plus surgery versus compression from a wound healing perspective, not significant, but from a recurrence of wound, highly significant. It's about 40% reduction in recurrence of wound with ablation plus compression. So that's why that actually, if your patient has a healed or active wound, it's a class 1A, and most insurances don't require compression therapy as a primary therapy, it's a conjunction therapy. There is a pharmacotherapy for venous disease. There's two current things, but it's micronized flavonoids is really what the stuff is, and this was from phlebology. And this has improvement in different things from taking this particular type of drug. Vascular is actually prescription, can only be obtained from specialty pharmacies, so it ends up being a little bit of a pain. Whereas vein formula sold on Amazon. So $35 for a month. And this vascular ends up being about the same price if you do get it insurance approved. So it ends up being a lot easier from a practice perspective, just if you do think a patient should try it. And the purpose is really less capillary leak. That's what they tell from their studies. So. This is a real patient of mine. This is ambulatory phlebectomy. Picture allowed by the patient. So ambulatory is super easy. It's, again, local anesthetic, no general anesthesia, office-based, walking out in an hour. So for those residual large varicose veins that may be painful or bleeding episode, we do ambulatory phlebectomy. So a small incision in the skin, it's about 2 millimeters. Typically a ball verity hook or something along those lines, undermine the skin, pull out the segment of vein, and the purpose is really to just interrupt that segment of vein for it to close. This is a patient immediately post-op, just steri strips, wrap the leg out the door, and these are pieces of vein that I pulled out.
We'll have usually done the ablation prior to
the ablation is
because that's the vein causing the issue.
So, it's an adjunct therapy on top of ablation. And then Varithena is another treatment that came out pretty recently. That's typically used for residual saphenous vein disease. So when we do the ablations, we're typically just doing proximal disease. If you do very low down in the calf, you can be very close to the nerve, cause permanent numbness. So we're typically doing from the knee up to the groin. Doing that when they come back, if they have residual reflux in the residual saphenous vein, you can use Varithena microfoam. It's really just CO2 foamed sclerosant polynovinol in a can form. So access in the vein under ultrasound, inject holding on both sides, you wait 3 minutes, wrap the leg, and they go on their way as well. It's super easy, it uses almost no anesthetic because it's all just foam sclerosant intravein. You can do it for some superficial varicosities as well, if they're either too deep to do phlebectomy or something along those lines. Sometimes you see that there's a branch that comes off of the distal saphenous remnant. This will go down that too and treat that. So it's a useful tool, just another tool in the box for treatment that we do right in the office. And then, of course, just straight sclerotherapy for residual spider veins. Sometimes covered for insurance as well. Bleeding episodes, significant discomfort, cellulitis episodes. They'll cover it from a medical perspective, also obviously from just a cosmetic perspective. Typically using polydocanol, again, sclera is the medication in our office at least. And pretty straightforward. So for SEEP1 without reflux, it's technically a trial of compression socks and then plus or minus sclerotherapy, depending on how it goes with the patient. SEEP1 to 4 for trial of compression socks again, and then plus or minus endovenous ablation and phlebectomy, and then for SEEP5 or greater and failed compression socks, you're getting ablation plus phlebectomy, maybe sclero, maybe everything. It depends on what's residual. Sometimes we'll just stage people out in a row depending on what their physical exam looks like. And continued compression therapy obviously as well. So that's the standard treatment. And then these are a couple of patients that let me take some photos. So this was an 8-week follow-up just from ablation alone, no other treatments, and significantly less edema on the left. Discoloration's improved significantly. Amount of discoloration to go away, I mean, it varies patient to patient, how long it's been there, how much hemosiderin's been deposited, staining-wise, so it varies, but typically lightens to some extent and significantly improved from a edema perspective. The patient was very happy. And then this is another one, a patient of mine that was 6 weeks after. You can see the horrible cellulitis and large bulging varicose veins over here, almost all gone. 6 weeks, that was just ablation alone. So very, very effective treatments. All nice office outpatient. And patients like that. So there's a lot of different causes for edema. We look at them all in our office. We do comprehensive evaluation and management right there. It's, we have all the diagnostic tools and the treatments right in our office. So the hospital stays, no big expensive CAT scans or anything like that. And prompt evaluations are always available for, we have four docs doing venous disease, myself, Dr. Verma, Dr. Gibbs, Dr. Zinn, so we're available and expanding into a lot of the other offices as well. Questions? Yes.
Can you talk about how your venous testing in your office is better than the conventional ones?
It is. So, there's certain things, there's a couple of different reasons why. Number one is insurance, okay? You have to have certain factors on your documentation for insurance to cover any of the stuff. So if you go to outside facility and they don't document duration time of your reflux, we're going to have to repeat the study again. Because without the duration of time, insurance isn't going to cover any of the actual therapies. So it's really important to have the documentation from the studies in order to get the treatments that are required. So that's actually one of the biggest things I see from some of the outside vendors is that they're not putting in.
A lot of places do the ultrasound incorrectly. Their patients are lying down or sitting down.
That's what I mean.
You have to be standing up.
You need to be standing. So that's, if you don't see it's lying down, you have to stand them up and do it again. So that's another thing. But the documentation of that, even in the report, a lot of the documentation sometimes in our report will say patient was standing, just to say, okay, we did the test right. And a lot of places. Repeat testing, unfortunately, when you have it done at an outside place, is pretty common. You probably see that at least 30 or 40% of the time.
In a lot of places, they'll just get a venous duplex, which is just
That's
rule out
an idea.
DVT.
So
They're
rule
not
out
looking
DVT
at the-
is fine.
They're not looking at the superficial veins, and then they're not doing the diameter, they're not doing the reflux, and then definitely they're not standing well. A lot of times I'll get these results from patients, they look like they have venous insufficiency. I'm like, your ultrasound isn't bad. Were you standing up? They're like, no, I was lying down on your anesthesia. It's going to be extremely under. We actually have them stand, even when they come back for vein procedures, I'll actually have them standing for a few minutes, and then I'll do a quick ultrasound myself just to see which vein I'm going to get into, because the moment they lie down or sit down, you see the veins just collapse very quickly. So you want to see them in their worst state. And if they do it up lying down, if some patient can't stand up, we'll write on a report, the degree of reflux may be significantly underestimated because the patient is supine.
So I feel like in the wound center, we see patients with a tremendous amount of mixed disease. Right? So rarely are we seeing patients with isolated disease of one of these specific problems. So I guess from your perspective and the way you guys treat patients, how would you approach that? And would you be able to handle it from the three other sides that we're handling on the wound side,
Sure.
maybe the compression management, but from the CHF side and
I try to be as covered as I can.
venous
I see definitely a lot of combined lymphedema and venous insufficiency. And recently, I've seen a lot of that for some reason, and I try to be pretty straightforward with the patients too. I can do an ablation. It may help you to some extent. It's probably not going to help you 100%. Your edema is not going to 100% go away, but you may feel better. And if your edema may be better controlled, you're still going to have to wear compression socks. So I try to be very upfront with them to let them know, hey, I see this stuff, and then I kind of put it a little bit on them. What do you want to do? These are non-wound patients. If it's a wound, I'll probably just do it. So,
Right.
but if it's a non-wound, I'd say, okay, we can either ablation, compression, try to mix and match what they feel is comfortable for them. But I do find that a lot of the lymphedema mixed patients do feel better after venous ablation. I mean, I've seen that a lot of times.
There's a lot of patients that I've had that had lymphedema for quite a long period of time. All of a sudden, they've got now more symptoms. Right. When we do an ultrasound, they have underlying lymphedema with superimposed venous insufficiency. So just like Adam, I'll talk to them. Like, you may feel. I've had several patients who, at first, I was very hesitant on doing those patients because I wasn't sure if this was going to help them. And many years ago, when I first started doing this kind of patient that was similar to that, her son is an interventional cardiologist and somewhere else. He's like, I think you should just do it. And I'm like, all right, well, give it a shot. If she actually feels better, definitely. Obviously, the lymphedema is still there.
And I think that's our challenge, right? So we're trying to press them, get the but some of these patients are in heart failure too, on top of it.
Right.
So it's trying to like
Or they have
co-manage
pulmonary
that as well.
hypertension, and they have right-sided heart failure.
Exactly.
And those are the toughest ones to treat, I think. The ones that have pure right-sided cor pulmonale, so underlying lung disease, emphysema.
And they're diabetic with renal failure.
Right. Patients you can give diuretics to, get some symptom relief, but then their kidneys don't like it. So those are challenging patients even for us. But sometimes, again, we can do certain, take a little bit of a diuretic, get a little bit of improvement in symptoms, and some compression. Maybe take a little hit in their renal function, which over time will improve.
So we can send those patients to you and sort of co-manage them from the wound perspective. And I think we're looking for
And
more
we
of
want
the
that
interventional-
co-management from the
Yeah, and that's what
We need
we're
that.
Sometimes they'll show us the wound. I'm like, listen, I don't know what to do with the wound.
Right.
I'm from the inside. We definitely want it.
So we want that help too,
co-management,
yeah,
because
we
we
need
don't
that.
know what to do
Yeah,
with
it's
the
addressing
outside.
all of the pieces, not just the one piece. 'Cause the venous side is one thing, but concurrently, these patients are so compromised.
They are. And they're complicated, they have a lot of,
They really do.
we do a lot of heart failure in the office too, and nursing follow-up, and a lot of stuff like that. So it's we're able to follow it, which is good, and look at all that. But yeah, we need your help with the wound, no questions.
And I think that's where the stopgap is for us at the wound center is, you're trying to send them to 3 different docs,
Right.
and that doesn't always fit for continuity of care and for progression in terms of seeing each side get addressed in a comprehensive way and expeditiously too.
Sure.
And it takes so long to get things done. So
So we try to get people in quick, and we even within our group, we'll still manage patients if needed, and if they, if there's a vein patient that Irma has that needs an urgent look, and I have an opening, I'll take a look and see what I can do, and go back.
and the services are available at which offices? Marlton?
Marlton, Washington Township.
Well, we see patients in all 5 of our offices for consult.
Right.
The
Okay.
actual interventions right now, we're doing at Marlton and Vineland, actually. And now we're going to start doing them in Washington Township. So
Okay, so that pretty much covers the geographic
But all of the
basis.
offices, we do, I do evals in Haddon Heights even,
Yeah.
but the interventions are done in Marlton.
Right, and we do evaluations. There's 4 of us that do venous work, and we see amongst the 4 of us, then we all go to one of, at least 2 of the 5 offices.
So follow up to that. So patients currently seeing one of your other cardiologists, right? One of your colleagues. Send them back.
Promise, there are no gross pictures. You guys can enjoy, your dinner. I'm happy, that we're having this gathering. I think this is probably our first kind of gathering since COVID hit. And we're all sick and tired of sitting, at home behind, our screens with a button-down shirt and pajama pants, so it's nice, to get dressed up, eventually. I'm Zahir Effect, one of the interventional cardiologists. I'm not one of the 4 that do vein work, but one of the interventionalists that work on arterial disease, including peripheral arterial disease. And this is a very important subject for, basically, both of us. I was looking at slides, you know, medical slides, and this one came up, and actually I liked it because, you know, it peripheral arterial disease, we're talking about multidisciplinary approach, and this is the embodiment of that. You know, this is something that can lead to some implications that may require surgical interventions, endovascular interventions, but also is its manifestation of atherosclerotic disease that have a lot of other implications, such as, you know, cardiac disease, stroke, etc. So the medical part is a very crucial part in managing those patients. Not to mention as well that, you know, even in those who have not yet developed, you know, cardiac disease or they're at risk for CVA, when they develop critical limb ischemia, they're at much higher risk than those with asymptomatic peripheral arterial disease. And despite all of this importance, it is still very, very much underdiagnosed and undertreated as well. So the 2021 ACC consensus statement had emphasized that this should be called peripheral arterial disease, because when you lump it under peripheral vascular disease, again, we're losing a lot of attention to this important subset of peripheral vascular disease. Like I said, it's very under-recognized, and in a study like 2-3 years ago in JAMA, they looked at primary care physicians and their level of kind of, you know, comfort with this particular disease, and only 2/3 basically were screening for peripheral arterial disease, and only 6% of those family physicians were comfortable in treating those patients and aware of the guidelines of how to approach this. A lot of those patients are asymptomatic or have atypical symptoms, but despite that, they're still at higher risk for having cardiovascular disease and having poor functional performance in the future. So again, emphasize the early detection of this particular illness. The worse the peripheral arterial disease, the worse the outcomes in those patients. And as you see, they looked at patients with mildly reduced ABIs, 0.8 to 0.9, and those were found to have increased mortality by almost twofolds compared to patients with severe disease. Now we're talking about ABIs that are significantly reduced, less than 0.7, and the mortality in this patient subset was fourfold higher. Basically, despite the simple kind of, you know, and proven recommendations to treat those, especially the early stages of peripheral arterial disease, the treatment is still lagging behind. And we're talking about things that we commonly, you know, use in our practice as cardiologists: aspirin, statin, anti-hypertensive medications, and tobacco cessation. The mainstay here is the exercise program, which is very underutilized, and a lot of it's because, you know, patients' willingness to participate, and out of the patients that we see, only few that are willing or, you know, that continue with those programs, but it remains the mainstay of treatment in those patients. So this had led, and we're talking about more than 30 years ago, to a group of cardiologists rising to, you know, advocate for a new specialty, not necessarily for cardiologists, but even for internists to start, you know, training in vascular medicine. And how's that different from vascular surgery? Obviously, vascular surgery is kind of the end of the line when people have significant disease. They require, that invasive treatment. We're talking here about recognizing the disease early on, knowing the pathophysiology of the disease, getting trained in identifying those patients, and treat them and treat their risk factors to prevent them from progressing to those stages where the risk and the mortality and the comorbidity is quite high. And again, the ACC in 2021 came up with some guidelines for such training programs. And it all focused again on the medical aspect of vascular medicine. That is, early detection, risk factor control, interpretation of those, studies, and then, applying the treatment even when it's an invasive treatment when it's indicated. What's interesting, I was listening to a podcast focusing on this. And despite, like I said, that concept, coming out almost 30 years ago, it's still number one not recognized by the ABIM and even by ACC, and there is no board certification for such specialties. There are a few programs around the country, and those programs have a vascular medicine lab. And I was shocked to learn that a lot of places, even places like Duke and Yale, they have 2 or 3 vascular labs. One run by cardiologists, one run by interventional radiologists, and one run by vascular surgery. And they compete with each other, which is a shame because at the end I think it is a disease process that requires all of us to come together rather than to compete with each other. So basically, like I alluded to this earlier, it is a disease with significant, implications if not treated early. And like you see, and focusing on things that you guys may encounter more often are those patients with critical limb ischemia, those with, arterial ulceration, non-healed ulcers, leg pain that was misinterpreted for quite some time. So when you look at the 1-year outcomes in those patients, 25% of those patients die from cardiovascular mortality, and almost a quarter require amputation, which is life-changing as well, not to mention that amputation itself increased their mortality down the road as well. And only half of those patients at 1 year, and this is not that far of following those patients, were still living with 2 limbs. Now, what we see quite often on our end are those with claudication. But we also, fail a lot of times to screen patients, and especially, in the world of cardiology, you're diabetic, you're a smoker, you're coming to us with angina, chances that you have peripheral arterial disease is quite high as well. So in these patients that we just talked about, the ones that are asymptomatic or atypical leg pain, the 5-year outcome was also quite devastating. Almost 1/5 of those patients, their claudication progressed. A small percentage progressed to become critical limb ischemia requiring amputation. But again, point you to this side of the slide, the mortality is still high from other non-vascular causes. So it's very, again, important for early detection and proper treatment in these patients. So what we should do is, again, those that have the risk, to develop peripheral arterial disease should all receive a very simple test, which is an ABI. And based on that, we have a better kind of, triaging of those patients. Those with abnormal results, although they're still asymptomatic, at least, we focus more on the risk factors. We treat them like we treat our cardiac patients, advocate for smoking cessation, treat their hypertension, their lipids, their diabetes. As far as those now with claudication and they have an abnormal ABIs, those are the ones that we will take it a step further and look into a more non-invasive studies such as duplex scan, which we commonly use in our office. And if the Doppler is very concerning, then the next step is to kind of get a non-invasive evaluation of their vascular anatomy by doing a CTA, and commonly used at all radiation centers, especially South Jersey Radiology. The ones that you guys always see, on your end, and those are the ones that come and require a more kind of invasive treatment. Those with ulcerations, non-healed ulcers, or resting pain, etc. Again, we have to look and see, like, some of you had suggested that this is, again, a comprehensive, approach. Those patients may all have, atherosclerosis, but a small subset may be, a thromboembolic disease that may need, further evaluation by looking for silent atrial fibrillation, TE sometimes to look for atherosclerotic burden or left atrial appendage thrombosis, or even, intracardiac shunts. Which, as cardiologists, we have the advantage of seeing those patients, approaching those patients from all different aspects, and that way treating even those unusual presentations that may not necessarily be driven by atherosclerotic disease. The thing is, the endovascular treatment for peripheral arterial disease have gained a momentum in the last few years, with especially advanced technology, with more personnel training in that, especially cardiologists and even vascular surgeons, some getting into the world of endovascular therapy. And this is very important because as compared to bypass surgery, it was found that the outcome in terms of preventing amputation was almost similar between the two studies, but the survival, the overall survival, had favored the endovascular therapy. And this is, it's multifactorial here, but bypass surgery is a risky procedure and carries a lot of morbidity and mortality. Compared and a long healing period compared to an endovascular therapy where a lot of patients go home the same day. Not to mention, again, the approach that we take with endovascular repair and therapy, paying attention more to all those factors, rather than when surgeons usually see them and do the bypass surgery, and it's kind of like one-stop shop until the next problem arises, and that reflected on the mortality in this patient. One thing I just wanted to bring up very quickly, which is the rising use of Xarelto. You guys have seen a lot of patients nowadays on Xarelto, but low dose Xarelto, 2.5 twice a day, as opposed to what we use for treatment of atrial fibrillation. A lot of our patients, you may have noticed, they come in, they're on Xarelto, the low dose, along with aspirin or Plavix, and this came out from the COMPASS trial, which looked at those patients at risk for peripheral arterial disease, and they prescribed them the low dose Xarelto, and it turns out that even those with no high risk features, there was still an improvement in terms of long-term morbidity and mortality with addition of Xarelto helpful. But the most benefit was seen in those in high risk population, those with cardiac disease, those who are diabetic, smokers. And the thing is, despite the improved mortality, there was no change in terms of bleeding risk, and patients had tolerated those medications very well. So you'll see a lot of patients, especially those cared for by cardiologists, now starting on the Xarelto, the low dose, for such disease. Now I just wanted to share this one quick, case, just to kind of, go over the scope of what we do and how things had evolved, like I said, from requiring surgery in majority of patients, even those with a very difficult anatomy, to trying with endovascular treatment first, and if they failed and if they have a complex, anatomy, then move on with vascular surgery option. This is a patient that I've seen. She's 71. All the risk, factors for cardiovascular disease. And she's been having a very progressive claudication. And after arguing with her for a few months about quitting smoking, and she promised, and she says, I can't do it, and then she promised again, and then she promised to go to an exercise program. We eventually, took her and did the angiogram. And basically, catheter sitting at the common femoral artery here, and then it bifurcates into the profunda, and the superficial femoral artery was totally occluded, at the very proximal part, and did not reconstitute until it basically reached the level of the popliteal artery. So a very, very long, area of total occlusion, and historically those patients used to go for a FemPop bypass. This lady, we, went with endovascular approach, and a lot of times you end up, in the, not in the true lumen, and that's why, I mentioned that with the advances of technology, we're having more success with this approach. This is a device it's a re-entry device that has even an ultrasound and IVUS on the tip. So you try and get all the way down, even if you're in the subintimal plane, until you reach, the plane where the artery reconstitutes, and the ultrasound shows you where the true lumen is. And as you kind of, point it towards the true lumen, you deploy a needle that is inside the catheter. And once you confirm that you're in the true lumen, you push your wire, and then, the rest is history. This is basically the final result. And she's feeling much, much better. She ended up going home that same day. Basically, what I'm advocating here is for, obviously, first and foremost is medically treating those patients, identifying their risk factors, reversing their risk factors, but I'm also advocating when the time comes and when they progress to, approach them with an minimally invasive endovascular approach. Also, what I'm advocating here is for those of us who are interventional cardiologists and work with peripheral arterial disease, the fact that, we work with very delicate coronary arteries, much smaller than those in the peripheral, we have developed the skills over time to be able to, manage those with much larger arteries even better. So we know how to play well, with the balloons, obviously. And lastly, I just want to say that, as this field is advancing, a lot of the procedures are now moved from the hospital to outpatient centers, and we're lucky to open our first outpatient vascular center almost 6 months ago now. in Haddon Heights. It's I can tell you from patients feedback that the experience has been very, very satisfying. A lot of patients hate to go to the hospital. There's a lot of anxiety that hospital can create. Here, on a given day, we're doing almost 4 of those, maybe 5 of those procedures. So they come in, they have kind of, a few patients to interact with, the staff that are very nice. And again, not having to go through the debacle of being in the hospital, everything is taken care of in terms of insurance, billing, etc., without, someone coming in and pounding on their head, show me your insurance card, etc. It's all within the system. So it's been a very successful experience, and we want to continue with this experience and obviously expand on this opportunity. And like Adam said, in terms of venous, disease, peripheral arterial disease is something not only that we are seeing, because of what we do and we deal with those patients hard, but it is something that we can help as well in terms of, preventing the progression to chronic or critical, lymphedema that could have, dreadful implications. We're also happy, if we're seeing those patients because they come to you with non-healed ulcer and, we're studying their anatomy and they need some endovascular repair, but also the fact that you guys are seeing them, they may need debridement, such work, they need, also, clearance from a cardiologist, so it's kind of like a one-stop shop. And at the end, the focus is patients, well-being. And with that, I thank you all, and thanks for nice to meet all of you.
Quick question about the absolute patency rate of the type of intervention you did for claudication.
Yes. So the patency rate compared in comparison now to bypass grafting is much higher. I'll tell you this, although that patient that I showed, I ended up putting stenting there, which may increase the risk of restenosis in the future. The majority of procedures that we do, involve a lot of debulking of the atherosclerotic burden, whether by laser, atherectomy, other forms of atherectomy that's shown, through different studies, to reduce the risk of restenosis. We try and avoid stenting as much as possible because it's one of the few factors that may affect the long-term patency. But a lot of times, you have a lot of recoiling after the balloon. You may have dissection, after the balloon, and we try, and limit, the type and the length, of stenting use. Now, also to kind of, way more on this. The technology had evolved in the last few years, and we have the advantage of using the drug-coated balloons. Those are still very expensive. They're not, widely available in all different places, including, certain hospitals. So we do sometimes these procedures down, for example, at Inspira Island, and they don't have these, balloons on shelf. I think, with any kind of new technology, new medications, time will hopefully reduce the cost, and that will benefit, patients in reducing their restenosis and improve their long-term patency as well.
So the patency you think is
with these
50% over maybe
3
years?
So I'm gonna say
Probably
this.
better than that. Most of the
Better
recent
than that?
studies are like 75%.
Yeah,
Over 3 years?
It's
Yeah.
really,
That's
patient driven at the end,
Okay.
and my experience had taught me that
It stops.
exactly those patients, despite doing the intervention, despite seeing them for their other issues, cardiac issues, we're still hitting a wall, kind of getting to them and change their habits. But like Adam said, you know, it is around that, you know, percentage, but, you know, in those that risk factors continue to be a problem, patency is much lower. It can be even lower than 50%. And, you know, although I've been with a group for 9 years, VJ, I've been with a group for 16. So VJ sees a lot of those, you know, recurrent offenders, you know, a few years later, speaks, you know, of the patency in this, you know, difficult patient
Still
population.
significantly more than it used to be.
Right. So
Yeah.
nowadays, it's not just we go in and wire the lesion, balloon, stent. So we use a lot of adjunct atherectomy devices. We use laser, we use a thing called CSI, which is orbital atherectomy. Spins for calcified lesions, it spins at 150,000 RPM, kind of like how we do rotoblator or the coronaries. There's another device that helps shave off the plaque. So depending
So
on
it's really more combination therapy.
Right.
Absolutely.
So it's not, so the patency rates have improved because we prep the lesions better, and the stenting rates have dropped because, again, we get a great, much better luminal improvement when we do adjunct some sort of debulking and prep the lesions after we do ballooning and if we need to stent. So it has evolved over the last many years. When I first started doing peripheral vascular intervention, 2006, there wasn't really much in terms of adjunct therapy. We used various things, but we didn't really know exactly how to use them at the time. And as the data evolved, we realized that all of our patients that we do interventions on will get some sort of vessel preparation before we do ballooning.
And even the use of intravascular ultrasounds helps us to understand what we're treating. So instead of just like if it's calcified, is it non-calcified, is it eccentric? So it really helps us in that kind of tool. The armamentarium is pretty big, so we can choose the right tool for the right job, which is really important.
We see some people who dabble in vascular intervention and they'll come in with these patients that are stented from stem to stern. And that's just
away.
stenosis. And we see a lot of those patients with second and third opinions. And sometimes, unfortunately, it's hard to get through all that hardware. So, for example, if I do a long CTO, a 300 millimeter long CTO through the SFA, I may put a 40 millimeter stent in because one area probably just was not. I rarely ever put a 300 millimeter stent, so you'll see that frequently, and those are the patients that come back with restenosis quite a bit, especially what we call primary patency and secondary patency. In peripheral intervention, we have two things that we look at. The first time you intervene on the same lesion, the second time you intervene on the same lesion. And it's much better the second time around, so we try to reserve stents unless there's a lot of recoil, there's dissection. Sometimes, as I was talking about the re-entry, sometimes when you re-enter a vessel, when we say re-enter, we're not outside of the entire vessel, we're outside of the true lumen within the planes of the vessel. And we re-enter there. Sometimes that area, when we laser, balloon, etc., it still recoils back, so we'll stent a short segment instead of putting a long stent. So that's kind of how modern day peripheral vascular intervention has evolved over the years. But again, people who dabble in it, it's easy to put a stent in because that requires no real, once you cross, throw a stent in, long stent, you're done, in and out. It requires time to vessel prep, do all these other things to minimize the amount of hardware. So, again, we do a lot of these, so for us, it's something that we've.
Yeah, I not only speaking for myself, but whenever there's an intervention, I'm always like looking what the other people have done, and I think I can speak for others. Like 80% of the time, we just prep the lesion, like BJ was saying, like I was saying, laser atherectomy or other form, and balloon angioplasty. And only 20% of the time we're using stenting because that's basically one factor that increases the risk of restenosis and affect the long-term patency. But again, I can't stress enough the patient, characteristics, and that's our, biggest kind of, frustration.
Us as well.
Yeah, exactly.
I think,
Or we wouldn't have work.
right.
Tonight, and a few things to say, and then I'm going to bring the residents up and talk about the study that we're doing, give you a little history of that. I had the advantage of seeing these guys do some work over the next couple of months, and I was very lucky in my practice because we had a really good team. We had it was before cardiology was into vascular work, but we had an interventional radiologist that was a savant, all Curtis. Chris is the only one with remember Paul. But the guy could open vessels like nobody could. And one of the big advantages of him, he was very patient and he could get all the way down distal vessels. And he had a very close association with vascular surgeons. If he couldn't do it, they intervened, which maybe Vijay, you could talk a little bit about your relationship.
So we work closely with vascular surgeons in all our different hospital areas. We go to like at Virtua, Dean Andrew and I are good friends. We we send patients back and forth because they're patients that I have collaborated on where they have common femoral disease where I can't do an endovascular intervention because of the bifurcation and where the location of the lesion is. He'll do a carotid, or he'll do a enterectomy, and I'll go in and then do a hybrid procedure. Do endovascular sending. We have relationships as well at Cooper, and as well as Jefferson and Shapiro with the vascular surgeons. So we try to work collaboratively with them because there's certain things that we're better at, certain things they're better at. And a lot of them over time have realized that as well, that they may or may not be vascular trained, but because as he alluded to earlier, I've probably done about 10,000 cardiac catheterizations by now, and we open up vessels in beating artery and beating heart. So for us, vascular intervention is just part of that, that same kind of skill set.
The other thing I was really impressed with is, I used to go down to Paul's lab and watch him work, and was fascinated by it. And then I got to see them do it. And the difference is the technology today. The ultrasound technology today is unbelievable. I mean, I saw stuff that I'd never seen before. It's fascinating. And I love, me, I love tech. And, yeah, it was pretty amazing. So this study, where this came from, a lot of one of my best friends is Marty Pressman up at Yale. And he lectured to you guys beginning of this year on bunions. But we're always, talking about the shop when we're together. We travel all over the place, we talk shop. And he started this study up at Yale with the Yale Cardiology Vascular Group. And he feels very strongly that, number one, just palpating pulses isn't enough. Some of the vascular guys, they come in, they say, oh, they got palpable pulses. Yeah, that's fine. But that's not enough. It's meaningless. But we really feel that doing a simpler handheld Doppler, whether it's absent or monophasic, gives you probably maybe as much information as the ABI. We want to compare it. And as we know, ABIs are not real good with diabetic patients. Aren't real predictive. So it's a simple study. The advantage to you guys is you should be able, if you document that Doppler study, you should be able to go from a 99213 to a 91214. Make a little extra money. And also, obviously, for the patient benefit. I look back at my practice, over the last couple of years, and there's a couple of things that I would have, most of all, pretty satisfied with what I did. There's a couple of things that I think I could have done better with. And I'll pass that on to you. One is, I think I was too cavalier with PAD and not being aggressive enough to refer, particularly later on in my practice when I didn't have the same guys that that were my buddies that I could get to real quick. I probably should have interviewed quicker. The other thing was biopsy. I would biopsy more. Has nothing to do with this subject, but if you see a lesion, biopsy everything. Yep. So with that, I'm going to bring up the residents and they'll talk a little about the study that we're proposing, which goes along very much with the lectures we just heard. Thank you. Can you get through?
Hello everyone, my name is Sony. I'm one of the first year podiatry residents at Virtua, and today I'll be talking to you guys about our study that is proposed by Dr. Q. Okay, so what is our project trying to do? So we're trying to see if Doppler exams can reliably predict severe peripheral arterial disease such that it may ultimately end up in intervention. So, handheld Dopplers are used readily, and particularly with our profession. There's not a lot of investigation that's been done on the reliability of clinical measures and interpretation of these clinical measures in these types of assessments. And not a lot of studies have been done with arteries below the knee in relation to peripheral arterial disease and ultrasound use. And so this gives us an opportunity to further investigate this. And so, why handheld Doppler? It's a low-cost diagnostic modality. It's non-invasive, non-ionizing radiations, mechanical ultrasound is. And we know that although there's a correlation between palpable pulses and systolic perfusion pressures, there's not a lot of certainty in the accuracy of measurement between these two. So this can be attributed to obviously user experience or examiner experience, but also things such as edema, neurovascular changes in diabetics, and subcutaneous fat development, and also the user or the examiner palpating their own fingertip pulsation. And so that's where a Doppler can help remedy this and provide some remedy some of the shortcomings in that regard. So, and in order to kind of perform this, it's important to have certain landmarks in mind to prevent discrepancies between measurements. So, the study that showed that utilizing the dorsalmost prominence of the navicular bone is a good way to detect your DP artery. They said within 1 to 1.5 centimeters, you'd be able to easily detect it with your Doppler. And obviously we know that the PT is between the groove of the medial mal and your Achilles tendon. And with your PT in a region that's 5 or so finger breadths from your lateral malleolus, approximately to the leg. Just a brief overview. We know that these are just visual analog or visual representation of these waveforms. We know that for normal lower extremity arterial Doppler, you have a triphasic signal, which demonstrates a systolic component, and then a peak systolic component, and then you have reverse flow and early diastole, and then forward flow and late diastole. And that's what's considered normal. Biphasics is considered abnormal if there's a transition from a triphasic signal somewhere more proximal along the vascular tree, and something monophasic is considered abnormal in itself. And so effectively, what is this project trying to do? So what we're doing is, measuring the Doppler on patients, and then compiling the data, and then patients that demonstrate either absent or monophasic phases signals that are established as such, we refer to the heart house for further evaluation, further workup, possible CTA, duplex Doppler to verify severe peripheral arterial disease, which may end up in intervention. And so, patients with, yes, that's what it said here. Okay, so, data collection, pretty simple. We have a Google document, you click on the link, you get directed to a web page. And this web page is simply, you provide provider information, patient information. You have a history of diabetes, peripheral vascular disease, any physical findings, what are the patient's symptoms, and what are the signals that you measure. And you simply submit that, and all the information will get compiled into an Excel sheet that we have access to. And with that, use that data to extrapolate information. And these are some of the follow-up questions that we'd ask ourselves. What kind of findings that did we find that are significant? What proportion of these patients are diabetic? Which proportions are smokers? How many of these patients have wounds? What is the range of age these patients with severe peripheral arterial disease? And what procedures were done, and were there any improvements in these patients? So that was just a simple overview of the project. And here's some references throughout that we'll be using, and yeah, thank you.
So we're gonna ask you one, two things. We do have, I have a little Google form thing that you can just do on your phone to fill out this thing for the patient and hit it, or you can contact one of the residents and they'll put the information in for you. But anytime you have a patient with criteria, obviously, you don't have to wait for that to refer to the heart house to one of these guys to do interventions. But we would like as many of those patients into our study as possible. As you know, things have changed in the residency evaluation. To do a research project is one of the key things now that they're really looking for. So it's really important that we follow up with this. Thanks.
Hi, you can